Can someone... Can you tell Sarah, Diana? Sarah at the front desk, thank you. So I think we're just about ready to kick off. Can I ask you if you can hear me? Good. Okay, people at the back nodding. That's excellent. Thanks for that. Look, you know that after lunch on a Friday at a conference in a hotel room with the lights turned down, with a decent meal in your tummy, it's really easy to stay awake. So this is a real test of our EMM gurus. I think I met all of you this morning. So look, just to reflect first of all this morning, I took quite a bit away from it. It's been a good learning experience. And my top three, for what it's worth. And I think I'm going bronze, silver, gold. So I really enjoyed the perspective Linda from the Alfred brought in particular, and starting to bring in the patient-centred approach. Some of the work the Commission's going to pick up next year and probably build on things you've already done, particularly Kate at the back, who's looking after the Consumer Medication Action Plan. We're going to kick off that kind of work probably in January. Again, closing the loop with greater patient engagement. It's not just a medicine, it's the same with diagnostics. Actually involving patients in open notes and lab results usually leads to less missed results. So well done. I really liked Catherine McVie getting up and saying, look, at the end of the day, if the doctors are going to prescribe on admission, we can say it's the pharmacist, so I can see a lot of nods there. So that was a particularly good perspective. And I think, Catherine, are you still here, or have you gone back to Prince of Wales? I think but the idea of just intimidating the young ones on their way through is a really good tactic. And the gold, I think, Patty, I really, really enjoyed your presentation. And you don't need to do a PowerPoint if you've got a great message. So that was good. And I also made me reflect on the funeral, the 98-year-old's funeral, and the loss to our country of Gough Whitlam, and all the good things that have seen a lot of us go to uni, perhaps get divorced without a lawyer, Medibank, and it was a golden time. It's time, 1972. Look, one of the things that came out today, I think we all know that if we had a good clinical pharmacist or perhaps a highly trained pharmacy technician, I haven't met any of them yet, 24 hours round the clock, Saturdays and Sundays, then MedRec would be better and the adverse drug event rate would reduce. I also know if you talk to the stroke people, if we had speech therapists around the clock, we'd have less pneumonia. And if you talk to the fractured neck of femur people, if we had physios 24/7, that'd be a lot better. And if I'm sure EDs would have shorter waiting times if there were more. But we know that, and our system, I think, in the public sector is at capacity. So we probably need to accept that we won't always be able to get all of those clinical pharmacists, even if they do end up paying for themselves through shorter length of stay, reduced adverse event rate, reduced sentinel event rate. But one of the reasons over the next couple of years the Commission's starting to look even more closely at the electronic medication management area is because we probably don't have too many other ways to go to start solving the population of a fairly full public health system. Now, we don't take the view that everything's solved by electronic medication management. We've done quite a bit of work, and I know a lot of you have in states, territories. I think EMM in hospitals is exponentially more complicated than in general practice. We have complex infusions, we have just sicker, more complicated patients, a lot more going on, a lot more providers. And in the we've seen already some areas where poorly planned implementations of an EMM system can actually lead to bad things happening. And there's a very significant paper about a paediatric hospital in the States where really concurrent with EMM implementation was an increase in risk-adjusted mortality. That's thought to be probably, the paper couldn't say why, it may have correlated to sort of big bang poor planning. The Commission started in this space in 2009. We sat down in partnership originally with the National Health Transition Authority. There were some research funds available, and what we wanted to do was look at What's the right way to implement EMM? Some of us, and Andrew and I were talking at lunchtime, and Marianne, been kicking around the system for a while. And when states make investments in clinical systems, you've got your scheduling, you've got your lab results, you've got your clinical pathways notes, but EMM is in every place I've been the hardest. It's at the right-hand end of the Gantt. And there's been a significant number of implementations with rollback, and there's been some implementations that haven't gone beyond partial. So we aren't here to say EMM is easy and just get it in and suddenly everything will go away. There's also an increase in academic activity. Looking at safety of health IT in general, not just of EMM. Not much literature, lots of editorials, quite a few tools coming into play, because what we know is, apart from getting your product selection right, implementation, it is a massive change project. So all of you know the med cycle. We have prescribers, we have dispensing, we have pharmacists checking and auditing, we have nurses like me administering badly in a hurry. And we spent some time in 2009-2010 with sites who had implemented EMM in hospitals. We asked them to be extremely honest about what didn't work as well as what did work. We put out our guide, and then the next 12 months we engaged with more sites to road test the guide and significantly rewrote it. And in that time, one or two of the hospitals actually rolled back some of their EMM they'd put in. So it ain't uncomplicated. We're not here to say that it is. This afternoon then we've got a couple of presentations. I guess looking forward, it occurred to me that if a patient presented to hospital with a really good med summary that covered their specialist as well as their GP, and it was legible, or in my computer that the med rec that we're all struggling with would be easier, might not be solved. So we've asked some sites to present about that this afternoon, and they're all going to do 20 minutes, not 30. That's a typing mistake on the program, although Rory's got 24 minutes, he said. So without further ado, I'd like to ask Maureen Hayward to come up. Now, Maureen's the pharmacist at St Vincent's, and I'm assuming that St Vincent's Sydney or St Vincent's Melbourne? Which one? Sydney, okay. And the Mater this morning, was that the Mater in Sydney or the Mater in Brisbane? Thank you. Good-o. Over to you, Maureen.
Thank you, Neville, and thank you all for staying. I'll try and make it a dynamic after lunch to keep you all awake for a little while. Where are we? Here we go. Aha! Oh, there's a screen down there. For those of you like me who haven't been up here, there's a screen down there so we know where we're at. I'm talking about electronically connecting the dots to improve patient safety, specifically about integrating MedRec within our electronic medication management system. There. So the aim of integrating it is to develop an automated MedRec functionality to improve patient safety and the outcomes related to the medication errors occurring during transitions of care. The next slide we might just flip past, because I think we've all seen this today. It's just the graphics are slightly different. MedRec, of course, is a process, and it comprises the four main steps associated. I'm quite nervous. Why am I nervous? We're all nice people. I've worked with a lot of you at varying hospitals, Queensland, New South Wales, over the years. So I just need to settle down and calm down. And I was only told 15 minutes, so I've got 5 minutes to spare anyway. You see, you're all laughing. You're all awake. Well done. These transitions are undertaken at every transition on the continuum of care. It obviously involves the concept of the admission reconciliation, a transition reconciliation, which we probably haven't talked as much about this morning as we could have. That can be transition between intensive care and a general ward. In my particular hospital, we move across to our palliative care areas and our rehab, which involves moving buildings and working with totally different teams, and we try to make sure that we've done transition reconciliations at that level of care. And then, of course, the discharge reconciliation that we've talked a fair bit about this morning. Conceptually straightforward. I think Neville put it absolutely beautifully 5 minutes ago. Implementing robust medication reconciliation within an EMMS can prove to be very, very difficult in our complex and dynamic healthcare settings. the background for St Vincent's Public Hospital at Darlinghurst in New South Wales, because there's quite a lot of us around the place, is that we've had fully implemented electronic medication management for a long, long time. We started in 2005, and by about 2009, every fully admitted inpatient in the hospital had an electronic med chart. We've been recording our medications on admission in our EMM system, predominantly by clinical pharmacists. And our discharge medication lists are generated within our EMM system. We knew there was lots of different methods of recording medication on admission histories, including the obvious front of the NIMC for the patients in ED. I don't think any of us mentioned the progress notes, but an awful lot of our medication histories are recorded there. And we developed a locally developed medication history on presentation form before the MMMP came out. But in 2010, we made a decision that we were going to stop recording them in all sorts of different places, and all medication histories would be recorded within the patient's electronic medication management system, which is the vendor we use produces a product called MedChart. This product also generates discharge medication lists for the hospital environment. The benefits of electronic documentation. Whoops, what did I do? There we go. The benefits of electronic documentation were also demonstrated when we did the National Inpatient Medication Chart Audit in 2012. As you can see, we were travelling at about 80% of our electronic charts had a medication history documented versus the national average of 28%. Now, I should say that the National Inpatient Medication Chart Audit is a 24-hour snapshot, and that's how we did it. So I can't tell you whether that was in 24 hours or 48 hours or 72 hours. So these figures are not comparable to what was being discussed at the High Five data this morning. In terms of developing integrated functionality, the Australian Commission on Safety and Quality in Healthcare's Medication Management Plan and the WHO High Fives project were used to inform the content and the design of our medications on admission systems and our MedRec systems. We then formalised our requirements, we formalised a scope of works and a statement of works, and we went and we talked to the MedChart vendor. Quite a few of us drove up to Canberra on lots and lots of times, leaving at 4 a.m. in the morning. It was very pleasant. We all became a very close team. We had IT people, nurses, pharmacists. We had a lovely time. It was very good. Good Noodle restaurants in Dixon, for those of you who don't spend a lot of time in Canberra. Do we have anyone from Canberra in the audience? Excellent. Excellent. Wonderful food in Canberra. We were able to do the first iteration of some user acceptance testing for the actual specialised automated MedRec. So we've been doing meds on admission. We've been presenting those meds on admissions to our doctors when they prescribe discharge scripts for quite a long time. But we wanted to get this as an automated functionality. And we did the first iteration in April 2013. There was lots of bugs. It's really complex. It's not easy. We sent it back and said, sorry, it's not going to work like that. So they've worked a lot further. I'm pressing these buttons very badly. In 2011, we went to a fully electronic discharge summary throughout the hospital, as a lot of the hospitals here have done. And that fully electronic discharge summary imports the patient's discharge prescription from MedChart straight into it, so there's no risk of omission at it. The fact that we did this presented us with a unique opportunity to review the business processes at our hospital, particularly medical and pharmacy business processes. And the key aspects of MedRec were highlighted during the implementation of the e-discharge summaries, culminating in a hospital-wide protocol that was endorsed by the executive and provided, I guess, the muscle for our MedRec presentations. So this is a copy of our protocol. I guess importantly, it provides a definition for medication reconciliation, clearly stipulating that MedRec is the responsibility of the treating team, assisted by clinical pharmacists. So it probably doesn't necessarily happen that way, but we do have a protocol, and that's the way our system is set up. And this follows on from the Commission's recommendation that MedRec's the shared responsibility amongst all healthcare professionals. There's some key wins for medication reconciliation in our policy document on MedRec. All patients are to have a discharge prescription. completed in MedChart by the medical team, regardless of whether we're providing medications from the hospital or not. Secondly, to support pharmacy business processes and to prevent multiple different iterations of discharge lists floating around. If a discrepancy is noted by pharmacy, and I think there often is, the doctors must update it in MedChart promptly, and the executive has in actual fact rung JMOs when that hasn't happened. It doesn't have to happen very often, and all of a sudden it's true. Honestly, you get the executive on board, that happens a few times, and it's absolutely amazing how the culture changes, because the registrars get the impression that they'll get in trouble if they don't do it, so the JMOs do it. On the other hand, you need a very strong chief executive officer to do that, or director of clinical governance, whichever of your organisational executive is prepared to take on that role. The pharmacy will not dispense any meds from a discharge list that is not correct, and that was very difficult for about the first 6 months, and people didn't believe that we meant it, but it's the only way to change things. And to ensure one source of truth for all medicines, if changes are made in the discharge script, the doctor also must re-import that new discharge script into the electronic discharge summary by the doctor. We have actually been sending our electronic discharge prescriptions up to the National PCEHR, or the National Electronic Health Record, since it went live. And so if we send up an incorrect e-discharge with an incorrect discharge prescription list, none of us are actually doing our patients any harm. I have used the word patient. I was worried because I didn't think the word patient was anywhere in this, and Patty, you have made us all, every single clinician in this room is thinking patients. Well done. The roles and responsibilities are quite outlined in our protocol. All parties involved in the medication reconciliation process, from medical staff, pharmacy staff, our marvellous IT staff, and our ward admin officers, who have a very important part to play in escalating incomplete discharge summaries. I did it again. So, medications on admission. So, the new functionality incorporates the medications on admission into the chart itself, with the aim of integrating the MedRec into the normal workflow of all clinicians. The functionality to add medicines onto the MOA is now as robust as the prescribing functionality, where previously it wasn't so great. This is now a buy-in for the doctors and saving time for the pharmacists. So when anyone, pharmacist, doctor, nurse, whomever is doing a meds on admission, searches for metoprolol, they're presented with some quick list options. The word quick list appears in different terminologies in different systems. I think Cerner uses order sentences. Some of the other healthcare vendors that all of you in the room no doubt will have struck will use other terminology to describe that. But whatever word you use, it's correct things that actually describe drug, dose, form, route, frequency and administration time. There's a lot more than 5 rights to prescribing well. We've also able to transfer our meds on admission or discharge meds from a previous episode of care, and we can pull them into the current meds on admission. Particularly useful for our frequent flyer patients or patients who failed discharge. I can't remember who it was, but I think it was the Alfred who was speaking earlier. We've also limited our look-back time to 6 months to prevent errors in looking back too far into the past. This isn't at our place, and I think isn't anywhere else either, an automatic import with a select all option. I was speaking to Andrew Hargraves yesterday, and we were all discussing about the fact you can't actually import full lists of medicines and assuming they're right. Each item has to be checked and verified by the clinician bringing it back into a system. So for our system, the clinician can only select and import individual line items, acting as a verification point at the time of entering. Setting a source. Now we've got a list of meds on admission, and you'll have to excuse the mixture of drugs there for those of you who can actually read them. It's just to demonstrate. As per the Commission's medication management plan, we need to document the sources we used. For this particular patient, can I read it? I've looked at a previous discharge list, I've spoken to the patient or his carer, and I've actually checked the National Electronic Health Record. So I've gone up and had a look at that patient's PCEHR and seen what the GP or a previous hospital's actually assigned there. I can assign those to one item or all of the items, depending on who I checked, which sources I can assign for different things. As you can see, we've now assigned those sources to each of those lines, and it's possible to identify who entered the meds on admission and when they did it, because these details are recorded against each medicine line. Meds on admission, the prescribing plan. This is another feature of the Commission's medication management plan that's been incorporated into our new automated functionality. The doctor can elect to continue a medication on admission, which will automatically convert the meds on admission order to an inpatient order. We've expanded the term withhold within our functionality to encompass two separate concepts. Firstly, to suspend a medicine temporarily, with the notion it may be reinitiated during admission. The example here is a metoprolol with an elderly patient who's had a fall. Was it low blood pressure? Do they want to restart it later? Or whether it's deliberately to withhold medicines until discharge. So if we go ahead and elect to continue 4 of these medicines, the little green spots, withhold the Blackmore's Macuvision because we don't carry that at St Vincent's and the patient didn't bring in their own, and we're suspending the beta blocker for the moment. The doctor can then activate the plan, and if you turn your attention to the numbers on the little top of the tabs in the red rectangle, you've seen we've gone from having no medicines on the patient's charts to having 3 scheduled medicines on the schedule tab and the warfarins on the variable dose tab. This is what the regular medicines now look like on that patient's medication chart. Oops, back. And down the bottom, you can see we've got a view of the suspended medicines at the bottom of the chart to serve as a visual prompt. You can see the patient's metoprolol order is sitting there waiting to be either ceased entirely or perhaps restarted during the admission or at discharge. Oops, I'm going too fast. Sorry, I'm still nervous. It's ridiculous, isn't it? There's 3 new screens that are embedded within the electronic chart. They are reconciliation views, and what they do is perform an electronic reconciliation by cross-comparing, depending on where you are, the meds on admission, the inpatient chart, and the discharge meds list. They effectively aid the identification of discrepancies across these 3 separate areas, providing opportunities to reconcile them with a prescribing plan. This is a view of the admission reconciliation. It compares the medicines on admission to the medicines on the inpatient chart. In this example, there's no meds listed for the meds on admission. We haven't got anyone in ED to do the meds on admission. We discussed previously about using the meds on admission list to create inpatient orders, but we know things don't always go from A to B. At times, doctors will prescribe directly onto the chart without documenting a meds on admission first, and we've introduced a forward-backwards concept here, providing pharmacists an efficient way to retrospectively populate a meds on admission using the inpatient chart orders, and, importantly, in doing so, to set up the reconciliation status for that medicine. So I can select the inpatient orders and add them to the medicines on admission tab, and the reconciliation status would then change from new to continued. So now the admission reconciliation's been done, the chart travels on. Drugs are ceased, doses are changed, new drugs are added. In this particular case, our patient's cyclosporin dose has been increased from 85 milligrams twice daily to 90 milligrams twice daily. You can see the ceased 85 milligrams BD in the greyed outlines at the bottom of the chart. Now, for those of you who know Kate Richardson's, this is her very favourite drug. So note this, all EMMSs have to be able to do cyclosporin capsules in some weird dose, and it's got to be movable, and then it has to be able to be prescribed on the PBS when the patient goes home. So that's why it's in this presentation. So let's see how this looks in the transition reconciliation screen, the view that electronically compares differences between the inpatient chart and the meds on admission. As you can see here, the status of the cyclosporin order has become changed, and the difference stated is that the dose on the MOA was 85 milligrams. From here, if I needed to, I could also add meds to the inpatient chart that was suspended or withheld. If I was a doctor, I'm a pharmacist, I obviously can't go and re-prescribe metoprolol, and the system wouldn't allow me to do so. Our doctors are going to have to do this. They haven't actually started doing this yet, and we understand that it's going to require quite some education for doctors to get them to go to this screen to re-prescribe that metoprolol order. But that's the only way we're going to get the continued status. If they prescribe it anew, it's going to appear as a new drug on the chart. We haven't got an answer for that yet, but we're going to work on it. At each of the reconciliation views, a clinician can verify that the reconciliation has been performed, and the system will record who did it and when they did it. We've made it as easy as possible for our clinicians to do the right thing at discharge and have actually built reconciliation into the process of creating a discharge medication list. This discharge reconciliation view aligns the discharge medicines together with the inpatient medicines and the meds on admission in one view, easily identifying what's been missed and what needs to be added to the discharge medications list. So to create the discharge list, the doctor would simply select the drugs from the inpatient or the meds on admission that they need the patient to continue taking on discharge, and in just a couple of mouse clicks, create a reconcile discharge list. Look at that, it worked, yay. This discharge list also doubles as an order to supply for St Vincent's Public Hospital Pharmacy, and for its patient take-home profile. It's written in plain English, no abbreviations, no BDs, no TDSs, no noctes. It's quite large, it's A4 format, so it's quite legible. The list is then imported into our electronic discharge summary, saving the doctor's time and eliminating transcription errors. Our particular system actually doesn't import it in the same format. If you can actually see on the right-hand side of the screen, it actually is a quite brief thing. I was interested to hear from Rocklands that yours, is it Rocklands, Henry? Rockingham in Western Australia, that theirs actually is being imported in a full A4 format, so it's legible in their e-discharge prescription summary. Different systems, I think that's really great, and maybe we should all be thinking about that sort of system as well. Importantly, the fact that it's been imported will be reflected in the reconciliation status and provide valuable information to the general practitioners and other healthcare providers after discharge. That should say medication safety in action and information transfer at discharge. We've been very fortunate in that we've got the University of New South Wales on site. I'm running out of time, 5 minutes, no problems. We've had a couple of papers where we've actually looked at our MedRec over the past few years, and EMM is certainly delivering improvements. The two papers shown here to demonstrate the results of using an electronic meds on admission to inform our electronic discharge lists. These papers were all written on our current functionality, not on the automated MedRec functionality that I've been showing you for the past few slides, but the stuff we've actually been using for the past 4 years. These papers show a reduction in transcription errors, and we were thrilled to see that 93.4% of discharge med lists were completed and accurate and available in our electronic discharge summary. And that included antibiotic duration, something that pharmacists are very passionate about. These papers also identified that we needed to improve our documentation of reasons for changing medicines. This was mentioned this morning as well. Documentation of why we change things is really difficult, but very, very important. Feedback from our local area GPs and our residential aged care facilities is that we need to concentrate on recommencing complementary and over-the-counter medicines, and I know the lady from the Alfred talked about that this morning as well. We often stop them at admission in hospitals. We don't carry them in a public hospital pharmacy. But these should be target areas for our new integrated medication reconciliation functionality. So where to from here? Conception to practice. We're about to receive the final build with all of our bug fixes, and we hope to go live in the new year when our new interns and residents start. We're planning on tricking them into thinking that this is business as usual and that they do the medication on admission first draft. Pharmacists will check it when they get there. We don't have pharmacists in ED very often. You need to get these things started and then they can be double verified later. This is going to require a well-designed education campaign and consideration about how to incorporate training into the orientation programs for our doctors, nurses, pharmacists and other healthcare professionals. We plan, and our patients, gosh, sorry, I forgot, yes. We plan to use the intervention tools and the resources made available by bodies such as the Australian Commission and the New South Wales Therapeutic Advisory Group. From past experience, during the implementation of our electronic MedChart in 2005, we know that our clinical leadership is crucial for successful implementation, and this is a tact we're going to be using yet again. Like any change, it's very important to audit and monitor its success or lack thereof. We'll be performing regular audits and compliance reviews to identify opportunities for improvement. Although I am presenting this work today, the acknowledgement and a lot of the credit needs to go to all of the team at St Vincent's. We have fabulous IT people. Our vendors have been incredibly useful, but more specifically, I guess, the other two EMMM pharmacists, Kate Richardson and Anmol Sandhu, who have really connected the dots and driven this work presented today. Thank you.
Thanks very much, Maureen. It's always a pleasure to work with St Vincent's Hospital in Sydney. Kate Richardson is part of the Commission Brains Trust for Medication Safety, particularly e-health, although she's not on the payroll. David Roff, your CIO, has been very supportive on a bunch of stuff, and we've seen a lot of leadership from that hospital. So well done. I introduced earlier Kate Oliver, who's going to be looking after the Consumer Medication Action Plan. Diana Ship's one of the other Commission pharmacy leads, and Diana's doing some work at the moment in a group with NETA, some pharmacy folk, some prescribers, on how we might look at consistently presenting medications on screen. So there's a lot of work on standard abbreviations, there's the AMT, but what are the safety issues around on-screen presentation initially to clinicians, because we've got dispensing systems, prescribing, administering, and we're building on work done in the UK. There's quite a lot of investment made there, but as usual in Australia it's got a bit hairy and a bit wider and a bit broader. So I don't know if you've all met Diana, but that's one of the projects she's leading at the moment, and we might come back and pick some of your brains next year when we go to formal consultation on that. The next speaker, Rory, is going to come and present on some of the work in Tasmania. What I noticed there is Hobart and Launceston, one's Cascade and one's Bogues. Now, have they got the same clinical systems or do they have different ones? Same clinical system. So Rory's got 23 and a half minutes. Over to you, Rory.
Can I just firstly say thank you for the invite to come here from Helen and all of you. I wasn't the original person to come here. There was a first person and they were overseas, and a second person, they went overseas, and so I'm the third person. So I've come here to talk to you about it. So I knew...
From Tasmania, you are overseas.
Yeah. I was going to welcome heckling, and I knew from the start it was going to be straight away. So good to see. Thanks, Neville. Okay. Let's get started. So I'm just going to give you a Tasmanian perspective on what we do, obviously, in Tasmania. The nice thing is it's a statewide program that we're using. Let's make sure I get this right. Okay, you all know this. We've all put it in every single one of our presentations, so I'm not going to bore you anymore with that. What I will do is give you some background. There are 4 public hospitals in Tasmania. Wow, that's a big number, but it does mean a lot to us. There are 4 public hospitals. And in the past, when I started in 1997, I come and go. I've spent most of my time at Medicare in recent years, but besides that, in the past, we were really, really poor at doing medrecs, if at all. They were ad hoc. They were not structured in any way, shape or form, and they were honestly pretty pathetic. We wrote in the notes and that was about it. I was quite shocked when I came back in the last 3 years to see how structured it had become, and it's really, really good. Obviously, they went while I was away to paper-based, which a lot of you probably might still use today. And now they've gone, or we have gone, I shouldn't say they, we have gone fully electronic. I will better stop there just for a second and say that if I do say anything inappropriate during this presentation, I do apologise. It's not meant to offend. It's to make sure that you're awake and listening to me. I'm sorry about that, because obviously after a large meal you will be tired. So we have this electronic or web-based system, which is the e-medication management system that we currently use. I'm not trying to promote it. I'm trying to give you an unbiased presentation. but obviously I'll probably show towards the positives because I use it on a daily basis in my gen med and my endocrinology work. But as I said, it is web-based and it's throughout the state. So no matter where the patient goes throughout the state, we have access to their records, basically. The program we use is called the Clinical Suite. Most of you may have heard of it, or some of you may have heard of it called Farm Care in the past, and you'll all probably shudder and not want to say anything. It then changed to EDS, or the Electronic Discharge Summary, and now it's been resurrected as the Clinical Suite. And all I can say is, from what I've heard from the previous pharmacists that have used the systems, is thank God I've come back now rather than a few years ago, because it was a bit of a debacle, if I can say that. Hopefully I won't, as I said, hopefully won't offend people. The nice thing with this Clinical Suite is it's statewide access. I've already pointed that out to you. We're sharing information between disciplines. In other words, what a pharmacist writes in there or types in there, a doctor has access to. A nurse could have access to it as well. It just depends on who's got the privileges, those sorts of things. And we're also linking medication management activities together. And what I mean by that is when I do a med rec or when I do an admission interview, fully accessible to the doctor to have a look at. Yes, as a pharmacist, we do the admission history interviews, but I'll come to all of that shortly. Okay, so in the Clinical Suite, as I said, I'm not trying to promote this, I'm just trying to show you how I use it. It's a useful tool to me because it allows me to do an admission interview. It also allows me to do a med rec, and I have to say out of those two, the admission interview is by far the most time consuming, as you could all appreciate. The med rec is quite simple once we've got the admission interview in there. It allows me to update, withdraw, change alerts, allergies, those sorts of things, and also update comorbidities in there of a patient. I have to say, and I'll say this towards the end as well, to begin with, it's a very, very slow process. So don't think it... I've got to say, handwritten ones, way, way faster. But we don't have the access to it wherever we go. This is the one thing I will say with this, and it's the one thing I want to get cemented in your head, is the fact that you can access it anywhere and multiple people can access it at the same time. It makes a huge difference. So we can obviously, the other thing we can do, as a pharmacist, I can generate counselling sheets from this, directly from the admission interview, from the med rec, those sorts of things as well, with clicks of buttons. It's relatively simple. When I show you the screen, you'll probably all cringe because it does look very, very busy. The other thing we can do is we write episode notes in there, just that on the event that on the weekend when we're working, if a pharmacist wants to check something out, there's a brief admission notes in there for us to check against medicines. So we do that just to try and speed up processes a little bit. With regards to doctors, this is still the Clinical Suite. A doctor can prepare a discharge prescription off the interviews that we've been doing as pharmacists. They can do discharge summaries, which get automatically populated. They now can do outpatient prescriptions, which has been recently introduced, and they can do outpatient summaries, or what they call consultation summaries. I'll call it an outpatient summary. So we've got it in an outpatient setting and a discharge or an inpatient setting. Doctors can play around with allergies as well if they wanted to. They don't tend to. It's left up to pharmacists to do that. And we're in the process of hopefully importing all of the allergies from our digital medical records into this environment so that they provide clinical or decision support. That leads me on to the next line here. I never know which one's the button to... Oh, here we go. I'm sorry for you guys on this side. I'll point... This is this area here we're talking about. Provides decision support. The nice thing with the Clinical Suite, if I can say that, is it's linked to our state formulary. It's also linked to MIMS, it's also linked to the PBS, and so it provides us with a lot of information. It's linked to a variety of other programs. So if I can say one thing, the Clinical Suite sits here and all these other systems feed into it. The problem is if one of those systems fails, then it looks bad on the Clinical Suite's part. And inevitably, and I hate to say this, I'm probably going to get in trouble if there's anyone on the webs watching this, but the one that fails us the most is iPharmacy. And that information sometimes does not get across to the Clinical Suite. So I've got to say, in all honesty, the Clinical Suite is quite robust. It's just the feeder systems that tend to let us down. So we've got feeder systems like IPM and PAS and those sorts of things, which feed in admin, and then we've obviously got iPharmacy directly feeding in there as well with medicines, like on discharge. The other thing we've got is the alerts, as I said, and we've got real-time decision support. So for doctors in particular, when they're prescribing things, it comes up with interactions and checks against the alerts, those sorts of things as well. Okay, so quickly, obviously the process we follow, we're trying to make it completely closed loop. It's not that way yet, but I can I'll show you what I do know so far. So when I go to work of a morning, medication admission interview is the first thing I'll do with the patient when they come in there. Obviously, trying to take the best possible medication history, basically. It's conducted as soon as possible. Ideally, everyone knows it should be within the first 24 hours, not always the case. And we obviously use a systematic approach. It utilises several sources. Again, you know that. We'll try and get at least 2, possibly 3, so it's usually a community pharmacy, maybe a GP, the patient, or we really, really encourage patient-owned medicines to come in. That's a big saver of time if they bring their own medicines in. I'm going to digress quickly. I know I've only got very limited time, but I had a bloke who brought in some Celebrex the other day, and he said, I'm no longer on it. Has anyone heard of a turducken? A turducken's where you have a chicken stuffed in a duck, stuffed in a turkey. And I took a photo of it because when I opened up his packet of Celebrex, yes, the Celebrex was in there, but there's also a box of Panadine Fort hidden in there as well, which the doctors weren't aware of. And he said, no, I'm on that as well, sort of thing. So I just thought this was the pharmacy version of a turducken, seeing this Celebrex with a Panadine Fort in there. The other thing is, as I said, with the interview, we check for allergies and notes. Again, these are things you already know. So I won't bore you by reading them out when you can all read them for yourselves, but I will get Jace to show up number 1, if that's all right, and just show you an example. So this is what I'm greeted with when I go to do a interview. Just when you look at it for the first time, this is probably the most important area that I can discuss because this is extremely busy. And this is probably where we start. And so this one here is the admission interview, so that's where we would start doing that. This one's the medication reconciliation. This is the discharge prescription, and this is the discharge summary. So this is the workflow that we all follow. So obviously the pharmacist comes along and does an interview, then the pharmacist does a med rec, and then we stop there, and then I'll go through that shortly, and then obviously the doctor can do the prescription, and the doctor can do the discharge summary. Jace, can I just get you to scroll down a little bit as well? Keep going. So that's it. That's lovely. So obviously when I see the patient, I'll take the best possible medication history that I can, and I'll put all this information in here. I was just about to point the electronic thing down here, but that's completely pointless. So obviously in this case here, I'm not used to such technology. It's going to be a Tasmanian joke in there somewhere. So what we've got here is the patient. This one is Susie E prescribed, purely hypothetical, purely a made-up one. Aspirin, takes 1 a day. Does she need any on supply? No, she doesn't, and she's still currently taking it. Same process followed down here. So this is what the patient's currently taking. If you scroll up a little bit, Jace, sorry, thank you for this. Keep going. We can assess the patients. So we've got the allergies that come across automatically. And you will notice up the top here, this is the comorbidities of the patient, which we've entered manually, and then obviously these allergies here are what we've entered as well. We're currently getting those imported at the moment, but on a daily basis, I'm usually having to add those in at the moment. The nice thing with that is once I've added it in there, if a doctor prescribes something, like a penicillin, it automatically comes up with an alert to them. All right, are there any questions on that screen at the moment, or I keep going? Cool, keep going, let's go. Can we go back to the presentation? Okay, so we've done the admission interview. The next thing I just wanted to point out to you is the chart review. It's currently paper-based still. You've all seen one of these, all know them well and truly. Again, these never used to be around when I first started in hospital pharmacy. The company that have got an e-chart ready to go, it's just I'm not willing to touch it until we've tested it for probably another year or 2, basically. So this is what we still use. So this is outside of the closed loop, if I can say that. So the doctors write the prescriptions. Can I just have a show of hands? Who uses purple pens in their hospital? Is it only... So we all do. Oh, wow, that's really cool. Do all the guys wear purple shirts as well? Just seems to be the way we've all gone. Just wanted to point out to you, sorry, I'm digressing and I've got to be careful of time. Obviously, we write this chart, and you'll notice straight away, if you'd paid attention to the previous admission interview, that duloxetine's not on there. So there's a problem here. So this is the chart. So once we've done the chart review, once we've done the admission interview, we then go on to the reconciliation. And again, this process is all self-explanatory. You all know this better than I do, probably. So the MedRec obviously compares the chart versus the admission interview. What I want to point out to you here is that we still generate a paper copy and put it in the patient's medical progress notes. This is all about patient safety. We've got to cover all bases. It would be nice if everyone used the electronic system. We are getting that way, I do apologise, but still we do back it up with paper-based. So, Jason, can I just get you to show me example number 2 again as well, if that's all right? So we've obviously moved on. Oh, sorry. We've obviously moved on from the admission interview and we've moved on to the MedRec, and the blue means it's in limbo at the moment. I'll just get you to scroll down just for a second. So there's the admission interview, admission medicine, that's fine. Do they need any on discharge? No, that's fine. So we'll go down a little bit more to all the multicoloured. And you can see here straight away that she's aspirin. I've clicked on continue, so it's no longer grey. So that's all I'm pointing out to you. But duloxetine hasn't been reconciled. It says here reconciled no. All I literally need to do, and I'm sorry to move from the camera, is click on these buttons. And highlight whatever I like and just move on basically. So I've just gone down through all of these, and in this case here, perindopril was withheld because she has altered renal function when she came in here. So we've got all these options. So we would just simply go through this, click, 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 and then move on basically. So Jace, can I get you to go back to the presentation, please? Once we've done the reconciliation, this is the paper copy we've got. And again, just like everyone else's, unfortunately the writing is so small, but I will point out to you, this says duloxetine here, and it says on admission, this is the column here, admission, and this is the column on the chart. It says here, the patient was taking this on admission, but then it says on the chart, not reconciled. We would highlight that to the doctor by writing in the patient's progress notes. If it's sinister enough, we would contact the doctor straight away and say, look, you've omitted this. And we also put information in here, like for instance, it says perindopril here, takes 1 a day on admission, but currently it's withheld because of poor renal function. So it allows us to put information in there. So not only does it help me, but the next person that comes along and reads it has a quick understanding of it as well. So that's really, really helpful. I noticed with MedChart, it goes across with all the information. Ours tends to flow down. It just depends on what your preference is. The nice thing with this chart, sorry, I'm doing the same thing now. The nice thing with this chart is it gives us the patient's pharmacy, it gives us the GP, and it gives us where their POMs are, where the sources of information we got, where we got it all from. So it's concise, and it pulls it down, and we can put it in for the notes to the doctors to read. Okay. So after the MedRec, once we've compared the admission versus the chart, and we've reconciled them, then we do chart reviews on a daily or second daily or weekly basis, depending on how busy you are as a pharmacist. The trick here is, though, now that we've done the reconciliation and we've checked all the charts and all that sort of stuff's under control, is when the doctors decide to do a discharge prescription. This is where it comes in handy, because the information that we put in there originally comes directly across to the doctor in the hospital or the intern that I'm dealing with and populates the information for them. So in this case here, as I said, Suzette prescribed was on aspirin, duloxetine, paracetamol, perindopril, and salbutamol, and it's basically said, okay, this is what she came in on. Doc, do you want to prescribe these? And they've all they've got to do is go add to script, add to script, add to script, add to script, and they can change the directions at any stage if they want, but that puts their medication history in by that one there. If they want to add new drugs, they just go to formulary, and we were mentioning, I think Maureen was mentioning about quick picks, they can do all those sorts of things as well. The problem I have with this system is it does a lot. And when you look at it for the first time, it's extremely busy. But the nice thing is, when I showed you up in the top right corner, those 4 little boxes, that's where most of our work's done. Makes life easy. This is a doctor's screen for writing a prescription. Again, all I'll point out to you here. So all the information that's come across from the admission interview has gone in, and they can use it to populate the prescription quite easily. This is, and over here on this side, this area here is the clinical information, and on the right-hand side basically is the regulatory information. So the PBS is built in there. So the nice thing is the doctors can basically, rather than having to go outside of this system, they can look up all the PBS restrictions, again, with the microphone. Don't point there. And these little yellow things here, basically they can open up and they can tell the doctor the restrictions, the authority, the streamline codes, all those sorts of things. So it makes their lives a lot easier. In saying that, though, when you look at it for the first time, you break into a sweat going, where do I start, what do I do? And that's why we have quite a bit of training going on with these guys. So again, all this information has come across mainly from the admission interview and also from the drug chart if they've added it in. And once they've entered all this information in there, they simply would print it out, and we move on to the next slide, hopefully. And this is the prescription, 5 minutes, cool, thank you very much. 4? Okay. Okay, so this is the prescription that would get printed out. We still need a paper-based copy because Medicare requires it, and let's not go there, but it can do electronic, fully electronic, but we still require paper. The nice thing with this is it's easy to read, very easy to read. So once we've done the discharge script, well, once it's printed off, we obviously reconcile it. So we do 2 reconciliation processes, one before and one after. We reconcile it to make sure the doctors haven't missed anything. And hopefully the next slide says that. Oops, we've gone by one. And it's obviously conducted by a clinical pharmacist. And once it's reconciled, we will dispense it. So then the prescription is dispensed in iPharmacy. And the nice thing is iPharmacy communicates, as I said to you earlier on, with this dispensing, with the clinical suite. And so it updates the patient's medication profile in the clinical suite. So, again, I'm jumping the gun by my slides. What's really, really important here is the information that we dispense in iPharmacy from that discharge script that we've just received gets populated into the patient's the record. One thing I haven't mentioned here, and I apologise, which we'll go back to, is all of this information does go up to a patient's electronic health record. That's one of the big things that's recently changed. I'm still working on it in the sense we're fine-tuning things, but basically anything a patient, if they've given consent, and I'm not sure why the slide didn't appear, I must have hidden it by accident, but when a doctor does it, actually we might just quickly go back because I've got 2 minutes left now. There it is. Up here. PCHR consent given. If a patient comes into hospital, it's automatically given a yes, but if they turn around and say, I don't want my information going up to my e-health record, the doctors just have to tick that and it stops anything going up there basically. We can then revoke that and bring it back, so we can switch it on and off depending on what the patient's desire is, because it is a personally controlled e-health record. But it is just simple and nice. The other thing is, obviously when this script is completed, the only thing I wanted to point out to you, I'm sorry for jumping all over the place, is it then is fed into the discharge summary automatically, as is the information from the admission interview basically. This information is all populated into the discharge summary, which then automatically gets emailed to the GP, automatically gets sent to the digital medical records we have in Tasmania, and as I said to you, it also goes up to the patient's e-health record if they've given us consent to do so. Jace, can I just get you to do 3? I've got 1 minute left. I'll just get you to scroll down a little bit if that's all right. So there's the allergies in that red and withdrawn. That's just bringing that across automatically, which is great. Those allergies provide decision support. You can keep going down a little bit more. You've got recommendations. You can see there's a variety of people can contribute in this discharge summary if they want to add things to it, which we are now doing a lot more of as pharmacists. Keep going down a little bit, Jace, if that's all right. Keep going down a little bit more. Keep going down, sorry. And then you've got the admission interview medicines there. And then if you look down on the far bottom bit here, it says use discharge script. Scroll, go down a little bit more if that's all right. So this is from the doctor's script here, that they've written all this information here. But if they just want to use the information that we've received from iPharmacy, they just click that button and it automatically populates the discharge summary from all the medicines that have been put into iPharmacy. So they've got a couple of choices. They do have to be very, very careful in what they tick and check and all those sorts of things, but it does tend to work well. Okay, goes down a little bit more. I think that's probably, we'll go back to the presentation and I'm on the home run now. So it does go to a variety of places. It's automatically emailed to those places, which makes a big difference rather than posting it out or faxing it out and not being able to read it. We are trying to make this completely closed loop. I won't go through that in the interest of time, but I will tell you, I don't know why, that's interesting. There should be a slide that says advantages as well. You always love modern technology. So the advantages is you can access it basically anywhere you want, no matter where you are in the hospital, if you've got a computer, all those sorts of things. The other thing is it flows on basically. In other words, what I put at the beginning is accessible to the doctors at the end if they want, or during at any stage. The disadvantages, I have to say, is it's really, really slow to begin with. And if you're not a touch typist, it can be even more frustrating. Human error, as we've all alluded to, is definitely still possible, and if you make an error at the beginning, hopefully it gets picked up along the way, but there's always the potential when we've got humans involved that an error will occur. It does rely on the availability and accuracy of other systems. As I said, there are a multitude into it, and there is some manual updating that we need to do as well, and you also need to be computer savvy. Okay, so with regards to everything, e-reconciliation does work if you've got reliable software, and I consider HCS or the Clinical Suite to be very reliable. You have to have good Wi-Fi. It makes a big difference. Having access to iPads, Androids, Windows tablets also makes a difference, and adequate training makes a huge difference. Getting those doctors, as we've all mentioned, someone mentioned earlier on about the young doctors, getting them early makes a big difference, because the young doctors wouldn't do anything else but do this now. The older doctors in outpatient setting, we're struggling with those. No disrespect to them. Is anyone on board? The question is, would I return to a paper-based reconciliations? Not if I don't have to. I would always stick with this electronic stuff now. Not that I'm a computer geek in any way, shape or form, but it just makes my life a lot easier, and looking up previous admissions makes such a big difference, having that information there and then. Oh, there it is. It's appeared out of nowhere. You send something over the internet to someone else and it changes. There's all the positives. Again, you're more than welcome to ask me any questions at any stage. I won't bore you with all that, but there are some definite positives to it. And thank you for listening. And that's it.
Thank you, Rory. That's great. Thank you, Rory, and thank you, Jace. Who's Jace? Who is it? Is that you? You're a civilian and you're doing all of that.
It's like Dickie Knee, if you remember Dickie Knee.
Yeah. I thought it was some sort of e-pharmacy guru. It's a civilian. Are you a pharmacist, Jason? Wow, well done. So thank you, Rory. That was excellent, and I think one of the critical success factors for EMM implementation would be having a Rory in your hospital, because you've got to have that energy and leadership to bring about the change. So well done. In my day, it was a green pen at Prince of Wales that pharmacists had. When did it go purple? Does anyone else use green pens? Just me. There you go. I bet they use green in Launceston. I know that. Okay. Our next speaker is Marianne Molinar. So for the correct spelling of that, look at the program, not the bios. Now, Marianne is a good colleague. She works at Eastern Health, and Eastern Health in Melbourne, one of those places that whenever we want to pilot something to commission and don't have any money, they always put their hand up. They've helped us with quite a few projects, so I don't know what that says about them. I think it means they take innovation seriously. Marianne is also a polymath, so apart from being a pharmacist, she's an informaticist and has just qualified this week as a musicologist. So without further ado, I'm going to hand over to the good Marianne.
Thanks, Neville. And thank you, Maureen and Rory, for your very excellent presentations and for making us laugh after lunch, and for showing us your screenshots of your electronic medical record. You'll all get to see screenshots of the Cerner one today from me. Now, thank you for giving me the opportunity to talk about medication reconciliation in the electronic medical record at Eastern Health. I have renamed my presentation, it's different than in the brochure, because I've called it now Opportunities and Challenges, as barriers sounds too insurmountable and we all love a challenge, or at least I do, and I know our project team does as well. I'm a bit like Maureen, I've got a bit nervous. It must be the thought of cameras. In Victoria, the Department of Health funded the implementation of an electronic medical record, which included medication, pathology and radiology orders. The tender was awarded to Cerner, and the first two agencies to go live were Eastern Health and the Royal Eye and Ear Hospital. For medications, this meant only discharge and outpatient prescriptions. Austin Health and Peninsula Health followed shortly after with inpatient medications for a limited subset of patients. The Victorian Department of Health worked with Cerner to customise the product, and this was called Health Smart. Oh. I've got to turn it up the right way, don't I? Yep. Each of the agencies rebranded their electronic medical record. Eastern Health called their Health Smart product EH Care. In this presentation, I will refer only to the medications component of EH Care. At Eastern Health, we currently have all 5 sites using EH Care for discharge and outpatient prescriptions. The sites are Box Hill Hospital, Maroondah Hospital and Angliss Hospital, and they're all acute hospitals, and the Peter James Centre and Wantirna Health, which are subacute. The Peter James Centre and Wantirna Health have both implemented the Inpatient Medication Administration Record, or the MAR. In Cerner, medication reconciliation is the process of converting what are called home medications into medications on administration, which can then be administered on the Medications Administration Record, or the MAR, and converting medications on the MAR into the discharge prescription. Currently, Peninsula Health and the Eye and Ear Hospital use this functionality. It is very complicated to explain why it is possible for both of these places to use the med regularity, but not suitable for the Austin Health or Eastern Health. The reason has a lot to do with the medications billed in the Peninsula product and the quantity and types of medications used at the eye and ear. The eye and ear hospital does not use the MAR, so converting to medications on admission isn't an issue for them. In this presentation, I will share with you the reasons Eastern Health has chosen not to implement medication reconciliation at this stage. 3 risk assessments and functionality testings have been undertaken over the last 20 months at the Austin and Eastern, and I would like to highlight what risks we have found to electronically performing medication reconciliation. What works on paper and through face-to-face communication is sometimes difficult to replicate electronically. For Catherine McVeigh, I don't think she's still here, I'd just tell to doctors that they can't wait for EMM to do something, that they actually need to get the processes right before putting in EMM, because that will be harder afterwards. So I'd like to show you how the process works in Cerner. But before we look at this, let's briefly look at the workflow as a flow diagram as determined by Cerner. Oh. Yeah, and I know you can't read it, and you're not supposed to read it, but none of you will be too astounded at the complexity, because we all know it's not a quick and easy task. And yet, I was very pleased to see that in the standard operating protocol, it looks so much easier and better, and that's much more encouraging, isn't it? No, right way round. Yeah, okay, and yeah, like both of the screens before, you can't actually read them very well, and I didn't realise you wouldn't be able to read it so very well, but anyway. Our example is a 93-year-old, normally extremely well female, Gwendolyn Alphabet, who has taken a turn for the worse with shortness of breath. She arrived into the emergency department having never been in this hospital before. The ED doctor suspects a community-acquired pneumonia and prescribes a bronchodilator and some antibiotics. When the patient's immediate concerns have been addressed, the doctor or any other health professional can go into the electronic medical record to document the medication history for the patient, and this is called or referred to as home medications in Cerner. The home medication screen is blank for Mrs. Alphabet, as she has not been into this hospital before. And I'll explain these columns at the top of the screen shortly. At home, Mrs. Alphabet uses a Symbicort turbohaler and a Ventolin puffer. Now let's have a look to see how these are entered. The doctor first searches for Symbicort and selects the appropriate turbohaler. This is a great example to show you, as there are not so many different Symbicort strengths and sizes on the market. Pharmacists on the project teams have built sentences that are routine and safe directions for the medications. We refer to these as order sentences, but they were the quick, whatever it was that Maureen called them, and everybody else has a different name. If a doctor selects one of the built sentences, the conversion of the home medication to an admission medication is a simple one. Now to document Mrs. Alphabet's Ventolin. Of interest to us is the bottom section, and specifically the Order Comments and Compliance tab. So I've pressed on the Comments tab. The types of issues entered into the comments field are similar to the sorts of issues a pharmacist would use a purple pen for, and possibly a green one. Anything added to this field shows on the MAR and gets printed on the discharge prescription. So it might be something like add tablet to water or something like that. The compliance field is used to note down issues that are not seen on the MAR and discharge prescription, such as the patient adherence as ascertained by health professionals. Please note that only one information source can be documented, and it is possible to use this space also to add in other information such as social or practical issues related to medications. After documenting the patient's home medications, these medications will appear on the patient's medication profile. And you can see the top two above, they're on the top. The conversion of home medications to medications on admission can now happen. This is done by selecting admission under the reconciliation tab. And you can you see that with the arrow? You can choose either admission or discharge on the top. So here is the admission reconciliation screen where the doctor makes a choice whether to continue or suspend the home medications. To continue a medication, the doctor would click on the column under the green arrow. To suspend a medication, they would click on the column under the red box. In our example for Mrs. Alphabet, the doctor has chosen to continue the newly prescribed ampicillin and to suspend the Symbicort because Mrs. Alphabet does not have the inspiratory capacity to inhale from a turbohaler at this stage. The reason for suspending a home medication is required to be entered, and you can see that down at the bottom of the screen. The reasons are actually built in. You can't write your own. This screenshot shows that the new doxycycline is to continue. The bit under the green arrow has been chosen. Now we have to make a decision about the salbutamol orders. The doctor decided to keep the increased dose of the new order and to suspend the home dose. And this is what the electronic drug chart, the MAR, looks like. Nurses click on the dose tiles to document when a dose is given. And because ampicillin is IV, the nurse will also be prompted to enter the site of administration. Now it's time to look at medication reconciliation on discharge. The prescriber selects discharge from the reconciliation tab, as you can see up the top there. This is the discharge medication reconciliation screen, and here we can see one of our challenges on the screen. The American workflow is to have the options to continue the medication, the green arrow, create a prescription, the pill bottle, or to stop the medication, the red square. Selection to continue the medication will not generate a prescription. This is not suitable for our workflow as we require all of the patient's medications to be documented on discharge, not just the ones requiring supply. This option is hard-coded, which means that Cerner cannot remove it. And we feel that it would need a lot of training to ensure the doctors do not select continue, because that's a fairly logical one, and that's the choice that they make in the admission medication screen. On conversion to a prescription, the auto-calculate for the quantity to be dispensed has been turned off, as the American option is 30 days, which may or may not be the PBS quantity. Because we have turned the auto-calculate off, the doctor must manually enter a dispense quantity. This means the doctor must know or find out what the PBS quantity is. That is what the PBS tab is for. If the dispense quantity and the dose unit do not match, and here I've circled doses for the dose, and we've got turbohaler for the dispense quantity, although it looks blank there. The doctor must click on the PBS tab to determine the quantity, select the correct dispense unit, and enter the dispense quantity. The dispense quantity and the dose unit must be the same, and that seems an odd problem, but it comes from how the order sentences are structured. For our next example of doxycycline, the dose unit tabs, and you can see that, and dispense quantity tabs do match. So there's no problem here. But the duration of the medication does not carry through to the discharge directions, and I've circled that area. Mrs. Alphabet has been ordered doxycycline for 5 days. This information does not go into the discharge prescription, so the doctor will need to remember how many days were left of her antibiotics. If the doctor doesn't remember or would like to check, they would have to navigate away from this screen and back to the MAR and then start all over again. This screenshot shows that the doctor only needs to deal with the orders they want to send the patient home on. All the remaining orders can be simply discontinued by clicking on the Do Not Continue Remaining Orders button on the bottom right-hand corner. You can see here that the doctor will send Mrs. Alphabet home on her usual dose of Ventolin and not continue with the increased dose. New medications can also be added at this time. In this example, the IV ampicillin has been discontinued and a new order for amoxicillin tablets is written. So we get to select the amoxicillin we'd like, and here we are discontinuing the ampicillin, and this is our final prescription, or what's going to go on the prescription. If and when Mrs. Alphabet is next admitted to the hospital, the previous prescriptions will appear in her documented home medications list. Her health professional can add, modify or remove any of the medications from this list when completing the medication history. So the 4 challenges I've highlighted in the example of Mrs. Alphabet are challenges with drugs that have a duration. Duration information from the MAR does not flow through to the MedRec on discharge screen. It is often high-risk medications that have duration, such as anti-infectives and oral chemotherapy agents. There is the option to continue a medication that does not produce a prescription. It has no effect, except to appear on the home medication screen when the patient comes back into hospital. There's a challenge of having a blank quantity for medications ordered on discharge, requiring the prescriber to know the PBS quantity or to look it up. And the incongruity with the dose unit and dispense quantity that they actually have to match. The last 3 of these challenges are specific to the Cerner program. I believe the challenge with the drugs that have a duration could be either on paper or electronic, MedRec, although it would be easier for a doctor transcribing from a medication chart to see how much longer the medication is to go for. Other challenges that are specific to the electronic system are, and this is going to be complicated, in the current medication build, the logical state hide show rules haven't been applied to the home medications catalogue, so that everything on the Multum drug catalogue shows. So here's an example of when a health professional searches for insulin in the home medication screen. Unless a health professional is very familiar with the build, it is easy to select an option that has no order sentences. Now, this all is going to sound like double Dutch to you, I know, when I talk about hide show rules and drug catalogues. So just go with me if I just do a very quick explanation of what that means. So a drug catalogue, it's the behind-the-scenes stuff, is how the drugs are named. And it's all actually on a big Excel spreadsheet, thousands and thousands of lines. A drug can be named as its primary or generic name, and in our example that would be something like insulin neutral. Its M synonym is the generic name plus the strength and form, so that would be insulin neutral, human recombinant 100 international units per mil injectable solution. And then the Y synonym is all of that plus the pack size, so you'd then add on your 5 by 3 mil or whatever it is. It also contains, the drug catalogue also contains all the brands or trade names. The N synonym is equivalent to the M but with the trade name, and the Z synonym is equivalent to the Y but with the trade name. What that all means, and this, I've actually grabbed a little quick slice of the Multum drug catalogue and just squeezed out all the other stuff of it. That means that there's a whole lot of stuff on there that we need to hide so that the doctors don't pick a whole lot of drug things that we haven't actually put order sentences against. And the rules for that are the hide show rules that are on a state basis. So let's go back and have a look at our insulin example. You can see there's lots of different synonyms that would not have order sentences there. And if a doctor chooses one that doesn't have an order sentence, then they need to complete all that information. And completing all the information is arduous, frustrating, and has a lower chance of a successful conversion onto an admission medication. Not all the boxes on the bottom of the screen must be completed for home medications, but if they are not, then there are problems with the conversion to an admissions medication. At the Eye and Ear Hospital, both pharmacists and nurses complete the home medication screen, and that's routine, both pharmacists and nurses. Anecdotally, the recording of the home medications is not always accurate, and some are better at it than others. And this often depends on the person's familiarity with medications, their forms, and their strengths. Eastern Health recommends that the state height show rules be applied to the medication catalogue, and then order sentences are built for the remaining medications showing. The other challenge is for those medications that are available for prescription in a care set or power plan. The sorts of medications that are only available in care sets or power plans are those that we want to force brand prescribing where brands are not bioequivalent, such as warfarin. Force the ordering of an additional task such as dose check or patch removal for high-risk medications. To ensure prescribers order efficiently when it is common for multiple orders of the same medication to be placed together. And to provide passive decision support in the form of text due to a lack of the functionality elsewhere in the system. Eastern Health currently has 150 drugs that are ordered as care sets or power plans, and all of these will need to be reviewed. I'm actually going to show you what a care set or a power plan looks like, and this is an example of what happens to medications that are only available in power plans. This screen shows warfarin as a home medication, and here we are at the admission medication reconciliation screen again. At admission medication reconciliation, the warfarin will fail to convert. And there are no options for the doctor to select, as warfarin is only available in a power plan for inpatient prescribing. The doctor would then have to discontinue the home warfarin order and manually add in the warfarin. And this is what a warfarin power plan looks like, and I apologise that you won't be able to read it very well because it actually just shows you that you can order it, withhold it, order it once a day, alternative days, and it has down the bottom that when the INR is due. So the whole power plan then forces the doctor to do the whole lot. Okay, so at Eastern Health, only the Peter James Centre and Wantirna Health have the complete patient journey in the electronic medical record. The medication reconciliation functionality has never been implemented for these two facilities. The current workflow for a discharge prescription is to print off the MAR or open a separate screen with the inpatient medications and manually transcribe the discharge medications. The EH project team are very keen to see that the medication reconciliation functionality is implemented and have tentative plans to at least roll out the discharge medication reconciliation functionality to the Peter James Centre and Wantirna Health to replace the current broken workflows. There are no plans yet to actually implement the home medications and medications on admissions part. The pharmacy would love to see a functioning MedRec as it would help with communication about patients between sites. So our recommendations from the project team are to put pressure on the Department of Health to implement the hide show rules to home medications, to implement a prompt of duration to medications that have a duration, so it at least remind doctors that they have to put a duration in for certain medications, to conduct training to prescribers to ignore the continue option on the discharge medication reconciliation screen, and to do a review of medications in care sets and power plans and see if there are alternative ways to ensure safe prescribing of these medications. And we need to find a solution to the blank quantity challenge for discharge prescriptions. And that's it. So finally, I just want to thank Melina Kung and Laura Fanning and Megan Zigamanis, who did all the testing and the hard work. And it was Melina and Laura who helped me with the screenshots and walked me through a lot of the problems that they actually found in the testing. So thank you.
Thanks, Marianne. And I think a lot of us who don't do the back end, there's so much work once you sign the contract for an AMM system to put it all together and maintain all of that stuff. And I know, Maureen, at Vinnie's, once you sort of got MedChart in, I think David Roth was able to get resources to permanently have folk just keeping it all up to date, putting in the new drugs, taking them out. It is an ongoing effort of work. It does beg the question, I guess, of what opportunities there are for perhaps deduplicating the work that a lot of you are doing separately, and that's something that probably does need thought. Some of the biggest states like New South Wales, I guess there are opportunities for deduplicating that work, but we are in a federation with public and private hospitals, and it ain't always that easy. So we're on the home stretch now, and our last couple of speakers are from New South Wales, from Sydney. Nina Machillo, who works at the Clinical Excellence Commission, and their offices are across the park, so you've got an easy commute back to work, Nina. And Andrew Hargraves, who's a pharmacist also with informatics skill set, and he's got a couple of jobs. I can't even describe them all, but he works for New South Wales Rolling Out Systems and works for the TAG, the Therapeutic Advisory Group, as well. Again, I think the challenges around Australia, so Rory, I think, mentioned a couple of public hospitals, 4 big ones in Tassie. New South Wales is a different shape. Our CEO used to be Director General, and I always try and think when I see her in the morning that she had 220 hospitals to get rung up about when things go wrong. It's a third of the country, so it is a different scale. And I think that brings some opportunities and also just makes it harder. So without any further ado, I'll ask Nina to... You kicking off, Nina, and then Andrew, or is it a joint act? Beauty, welcome. Our KPI is 3:20.
Okay, thank you. Okay, just see how this works. Yep, it's working good. First of all, I thought I'd just explain, for those of you who don't know about the Clinical Excellence Commission in New South Wales, what our function is. So the Clinical Excellence Commission is responsible for leading safety and quality improvement in the New South Wales public health system. And we do this in a number of ways. We look at identifying risks and opportunities for improvement. We provide support, advice, tools and information to help our districts, and we work collaboratively with patients, clinicians and managers and the broader community. The first half of the presentation, I'll talk about the CC Continuity of Medication Management Program and the Medication Reconciliation Toolkit, which has been developed as part of the program. And the second half of the presentation, I'll hand over to Andrew, who'll describe how eHealth New South Wales, together with the CEC tools, will be assisting sites as they transition towards using electronic tools to facilitate medication reconciliation. So the CEC Continuity of Medication Management Program supports a safe and quality use of medicines at transfers of care. We decided to focus on medication reconciliation because we know that's an international recognised strategy to improve continuity of care and reduces adverse drug reactions, as we all know. We also wanted to provide local health districts with some tools and resources to help them meet the National Safety and Quality Health Service Standards, which has a lot of the continuity criteria. And it's guided by the Continuity of Medication Management Expert Advisory Group. So that group consists of nurses, doctors and pharmacists. It's multidisciplinary. It has representatives from most of our LHDs, so metropolitan, regional and rural sites. So why a toolkit? Well, we recognise there was a definite gap evident in New South Wales health system. In 2013, we had a statewide quality system assessment, which is a self-assessment process coordinated by the CEC, which found that only 56% of New South Wales LHDs had put in place a policy framework to guide the practice of medication reconciliation in their facilities. There was also the new National Safety and Quality Health Service Standards to meet, as I mentioned earlier, And so we realised there were resources that were required to assist our sites to meet those standards. We also found that across New South Wales health facilities there was a significant variation between sites, from those that had no formal reconciliation process to those that had some in certain pockets of their hospitals to others which had quite good medication reconciliation processes, and those are the ones I think that are here today. So the resources within the toolkit we thought needed to be adaptable to suit all of those sites. So to help sites who haven't actually started on the journey to commence their journey with MedRec, those sites that had to review their current practices and see where the gaps are still remaining, to help actually improve their current activity. So with the toolkit, we wanted to promote medication reconciliation as a multidisciplinary activity. But as we all know, when we do say that it's everyone's business, no one actually takes responsibility for it. It's always somebody else's role. So we wanted to incorporate clinical practice improvement and redesign methodology into the process. So we wanted to actually get teams to form multidisciplinary teams, work on it together, define their roles and responsibilities within each unit, because it will vary between each unit, it'll vary between each hospital. And we wanted to embed it into clinical practice and not as an add-on. And I think some of the statements earlier today was saying that that was how it was becoming successful. Also had to be recognised to be a continual improvement activity. It wasn't going to be something that happened overnight. It's going to be a journey that needed continual activity. And it also had to have tools in it that will sustain and spread the activity. And we had to actually prepare sites that don't already have standard MedRec process occurring to prepare them for the electronic tools that were going to become available. So we wanted to build on lessons learned. So we looked at international resources. So we looked at all the toolkits that are around, and there's many. The ones from the US, the Marquis toolkits, the Match toolkit, the European Union toolkit box. There's a number of others as well. And, of course, the World Health Organization High Fives program. So we looked at that and looked at what are all the lessons learned, and some of them are all spoken to about today as well. So the importance of motivating the frontline staff. They need to know that it's important. So medical officers, nurses and pharmacists all need to know that this is an important thing to do. So involving, making sure that patient stories were shared, making sure there was a clinical champion and someone to actually lead the process and always be there to encourage people to continue, because it does get quite frustrating, as we all know, when we keep getting the barriers for moving forward. Important to collect early baseline data to find out, well, what are the current gaps in the system and where do we start? Where are the processes we want to start at first? Getting that leadership support, so knowing that without leadership support it is going to be quite difficult, especially if we're expecting clinicians to add to their roles and current responsibilities. Educational tools are obvious, needing to get a common understanding of what medication reconciliation is amongst the team, not just the pharmacists, so that all the nurses, the doctors and even patients know what we're on about. And also having that continual review and feedback of processes and trying to build in the auditing into your everyday practice. So looking at one case every day rather than waiting at the end of the month to look at 20 cases, because it is quite time consuming to get that information. So our toolkit consists of 5 different areas: establishing governance, improving practice, education and training, monitoring and evaluation, and sustaining and spreading. So our establishing governance area has things like committee brief templates. It's got guides on how to form sorry if you can't see that very well, how to form a quality improvement team, a readiness assessment tool. Is the organisation actually ready to start on this journey, and what are the barriers that are actually making them not ready? Is there a common understanding? Do they understand the problem? And focusing on fixing those first before you even actually start on the journey. Improving practice tools. So how do you actually map a process? What are the clinical practice improvement tools that you can use to actually sit down with your team to actually map out what your current process is in and move them to what the process you want it to be. We've got some local operating protocols, procedure templates, frequently asked questions to help people along that journey. The education and training, so we've got training on obtaining a best possible medication history, some guides, but also just what medication reconciliation is about. So again, bringing people together with a common understanding, and also talking about medication reconciliation beyond admission. I think someone else mentioned that we have been talking a lot about admission and discharge, but there's also those transfers, so having some education around that as well. With the monitoring and evaluation, we've got a number of different tools for that. We've got a really comprehensive audit tool which will assist sites to measure how many good best possible medication histories are occurring, but also how many patients are actually getting omissions or discrepancies, how many discharge summaries are actually accurate. And then we've got just a snapshot audit tool for if you're wanting just to check if your processes are occurring, and you can have a quick look at what's happening in the system. And then we've got our sustaining and spreading tools. So we've got a number of different posters to help again to increase the awareness of the problem amongst your clinicians. We've got a poster for consumers as well for their role in the whole process as well. And we've got some templates like run sheets to help people actually monitor and show how their progress is going. So that, and a template to help report back to your executives to show them what's happening, show them what the gaps that are still occurring, show your improvements, and hopefully be able to get a better support for continuing. We did pilot most of these tools for hospitals, metropolitan and regional sites, and we did actually send out some of our audit tools to other sites who requested them, and we didn't actually give them our support in doing it, but we did get some good feedback from them. So we felt that our tools were actually useful for them, so that was good. And our future plans, all these tools will become available on our webpage. And the Clinical Excellence Commission, it is in an internet page, so it's accessible to anybody. We'll communicate the availability of the toolkit to all our sites, and we'll officially launch it in early 2015. The other thing we are doing is partnering with eHealth New South Wales, because we recognise that before people actually move to electronic systems, if they don't actually have the processes in place or a common understanding of what's actually needed, it is going to be a lot more difficult for them. And I'm just going to hand over to Andrew so he can continue.
Hi everyone. So just a quick bit about eHealth New South Wales. eHealth New South Wales is a part of the New South Wales Ministry of Health, which is responsible for delivering clinical programs. Note that's clinical programs and not IT projects. We recognise that EMM, intensive care clinical information systems, electronic medical records are much more clinical change projects than they are IT projects, irrespective of the number of geeks and boffins that are involved in the whole organisation. I also work with New South Wales TAG, and we have an organisation which promotes medication reconciliation and quality use of medicines, and have a number of tools that are available. Margaret mentioned them this morning, the recent QM indicators which have been published just a couple of weeks ago, as well as some data collection tools to support sites in medication reconciliation. A bit about the EMM program in New South Wales. It's a $170 million program which is targeted to roll out full electronic medicines management systems to 14 sites across New South Wales, as well as supporting EMM initiatives in a number of other sites. It's a centrally led program but locally delivered, which has its fantastic benefits, especially sitting in the centrally led part where we can shape and drive things across the state and shift all of the risk to the LHDs. We also have a lead site model that is currently in process now. So we have 3 initial sites which are designing and building at the moment, to be followed on by the remainder of the sites across New South Wales, or the remainder of the districts, I should say, with detailed planning studies that are in place at the moment. The last thing I need to say about the EMM program is that it's currently in a procurement phase, and because of that, I won't talk about vendors in particular, and any mention that I do make of any particular vendor can't be seen to be providing preference or anything else. I'm specifically going to try not to talk about systems. We've seen 3 examples of different systems today. They all have their benefits and their drawbacks, and they're all at their heart very similar. So we're really excited to partner with the Clinical Excellence Commission to deliver the IMRAD project. It's the IMRAD project because it wouldn't be an eHealth project if it wasn't an acronym. It stands for Improving Medication Records on Admission and Discharge. We specifically tried to dissociate the idea of the project from medication reconciliation. We wanted to focus on the concept that an improvement in medication records means any step forward. It doesn't mean finding the silver bullet that makes it perfect. It recognises the fact that the silver bullet solution, if it did exist, would be far more reaching than a technology solution alone. And that... I had something really eloquent to say. And it's gone. So the first part, wrong. I found it again. So the 3 streams of activity of our program are about supporting LHDs to do projects, to support development of tools within the electronic medical record for New South Wales, and to support the development of tools within the electronic medication management system. The local health district kind of stream of activity of the project is the heavy lifting stream. This is where the clinical redesign work will be done. This is where we partner with the Clinical Excellence Commission, and it's where all the solution design, implementation of whatever solution is ultimately developed will be. Clinical redesign provides us the opportunity to really understand the problem. I think within medicines reconciliation, broadly, we think we understand the problem, and I think different sites have a much better view of the problem they have at their local site. But before we kick off and before we commence an investment, I think it's really important that we stop and really try and understand the exact opportunities that exist within our site and the exact barriers that exist, and the understanding the problem diagnostic phase with using the CEC toolkit will afford sites to understand that. The implementation solution design phase, rather than just picking at the very start a thing that we want to do, rather getting people into a room and designing a solution that fits and meets the challenges and the opportunities that are faced by the site is really important. And then obviously conducting monitoring both pre and post and being able to demonstrate the benefit. So I guess the question for why an electronic medication management program would be bothering to do anything with electronic medical record is a worthwhile one. We will have a variation in adoption of EMM systems across New South Wales. There are a host of reasons for that. There are the ones that we say out loud, like sites' readiness and technology and willingness to adopt. There's the ones we don't like to say so much. It's like cost and rollout times and schedule and ability of vendors to meet our timeframes. But I think, as Neville alluded to, New South Wales is a very large state. It's got a lot of hospitals, and we know that we're not going to have a full closed-loop EMM system in 220 hospitals by the close of the program in 4 years' time. So we just call that a spade, I think. Gabriel this morning mentioned some shortcomings about our EMR. I think warts and all was mentioned, although she might have ducked off to get back to southern New South Wales now. We're trying to work on some enhancements to the EMR so that it's maybe a little bit less warty, and also design some things within the EMM system which sort of present some good opportunities. I think the minimum requirements that we're really shooting for are the ability to document a valid and verified medication history, to document the changes that have happened to the medicines throughout the admission, to be able to communicate a final medication list to the general practitioner and ideally the patient as well, and to store the medication list for future admissions. I think the EMM functionality will go further than that, but if we could progress to a point where every site in New South Wales had an electronic system which at least met those 4 requirements, would be a number of steps in advance of where we are now. I think the last thing I want to say is that medication reconciliation isn't about gadgets and gizmos and widgets. It's not about order sentences or quick lists. It's not about hide-show rules or drug catalogues. Medication reconciliation is about people and processes. It's about intelligent, dedicated healthcare professionals that know what medication reconciliation is, understand how to do it and care enough to do it. It's about patients who expect the information, understand the need for them to collaborate and demand their right to be informed, and about processes that support the availability of systems that allow healthcare professionals to conduct medication reconciliation activity and document that information in whatever tool is available. I'd implore you to dispel the myth out there that electronic meds management systems will fix medication reconciliation as a problem. The mention has been numerous today about the need to get systems in place in advance of EMM systems because they are crap in, crap out systems. It really doesn't matter how wonderful the automation is or how wonderful the gadget is. People are the people that need to use it, people need to understand, and they're the ones that are going to drive the whole process. And that's my last slide. So thank you for inviting me to present, and I think we're happy to take questions. Are we doing a panel?
Can you two stay up here? Marianne and Maureen, you're able to come up. Marianne and Maureen, and Rory as well. So thanks for that. One of the things I really enjoy, the Clinical Excellence Commission New South Wales is about 60 metres up the road from us, and their CEO, Cliff Hughes, who was a cardiothoracic surgeon at RPA and has got a long profile in safety. The way Nina presented, well, here's the stuff you do upstream, governance, leadership, materials. If you've got 220 hospitals and someone's doing good materials, it's such a nice way to do it. And I think they sort of bring that governance approach, the leadership, and then you sort of get on with the crunchy project. So I think that kind of works. I see the hand of Bernie Harrison. You've got the run tools that people get to sort of do their monitoring as they go. The 1, 2, 3, 4 steps, which is kind of, as a nurse in ED, 4 is probably enough things for me to think about, because I've also got the VTE people wanting me to worry about that, and you've got the falls people, and you've got that. So 4 steps is probably all I can deal with at the start of a shift to the new poster, so well done. I'm just wondering if folk have got any questions. We've got Diana and Helen running around with microphones poised. Who has the first question? Linda. Linda from Alfred Health, formerly Prince of Wales, my alma mater.
Hello. I just wanted to ask, as we don't have an electronic MRF, the folk who are using an electronic MRF, how do you actually enter the data? Do you scribble it all on a piece of paper and then run to your computer and enter it all in, or do you get a little tablet and sit there typing it in while you talk to the patient, or how does it physically work? I've seen it work in a hospital I visited overseas, and it was sort of memorised and then run to the computer and enter it in. So I'm just interested in the
So thanks, Linda. That's
thing.
Good. We're going to have 4 answers. Has anyone watched Q&A, on Monday night? The first question is usually a speech.
But you should be in the middle, Neville.
So
we don't stand on the other side of you.
No, you've all got microphones, so away we go. Rory first.
Good question. My answer to that is some people do use iPads. We've actually got most of our clinical pharmacists got iPads. I prefer Android personally, and I'll do it with my Android because it's got a keyboard on it. Obviously having the Wi-Fi in the room is important. But the other thing is we've got thousands of blue reconciliation forms still, the paper-based ones, still sitting on a shelf at our pharmacy. So we actually use those and scribble all the information on there and then go and type it in. Obviously, the first time, as I said, it's quite time-consuming. But then from then on in, it's all electronic from there, that way forward sort of thing. But we tend to use iPads or Androids if we can at some stage.
Tablet is the term, the brand neutral term, tablet.
Right, tablet, or Microsoft.
Over to you, Maureen.
Along the lines of Rory, each of the clinical pharmacists on a ward has a laptop on a trolley, which is theirs to take around. Some of us have Android tablets, but it's a bring-your-own-device system. The hospital doesn't provide those. MedChart will use iPads, but our hospital Corpaz patient admission system won't. It's Android or Windows-based only. So iPads can't be used to actually access a patient if you want to find out anything about them. So that's a problem there. So laptops on trolleys, which you carry around with you and sit by the bed. Hatrix was bought by IBA in New Zealand, which was bought by CSC, which is an international, and they've renamed it on several occasions.
Same system.
It's the same system that we went live with in 2005, and it's now called MedChart, yeah.
So laptops, otherwise known as computers on wheels or cows. Marianne, I believe your cows went missing.
Oh, don't tell the world that, Neville. It's embarrassing. Linda, we actually are still using a paper-based MedRec. So we haven't implemented MedRec in our electronic system. Those, Peter James Centre and One Turner Health that do have an electronic inpatient chart still do their own MedRec on paper, and that's kept with the patient notes by the bedside. So we've still actually got a bit of this and a bit of that. We're trying to get MedRec in, but it'll be the discharge, not the admission at this stage, so paper-based.
Andre?
I'll just cop out and say the sites in New South Wales will choose their own devices. Most likely they'll be computers and on wheels and tablets, but they'll be mixed in with hand documentation and writing back into the system. I think we just need to balance the kind of enormous device wheeling into the patient room with still being able to provide a personal touch. Although I would note that everyone who goes to see a general practitioner will sit there whilst their GP will write into a computer. So I think from consumers...
So we're not in bed, you see, when we're seeing the GP, we're sitting next to her.
Sometimes, but yeah.
Patients are in bed.
What was I going to say? I think that consumers are expecting people to be using computers, and from the ones I've spoken to about it. So I don't think that there's necessarily a barrier to using devices. I think you just need to use it smart.
When we did the EMM guide and we were polling folk who'd done it, and I think NT's probably got quite a lot of runs on the board with EMM, the advice from them was just this was a while back, get lots of laptops. Don't go for the highly spec'd. Don't let someone tell you need the flashest, poshest, expensive one. Just get lots with the money, because there's never quite enough. Next question. Margaret.
Both Rory and Maureen mentioned sending the information on discharge up to the personally controlled electronic health record, and I just wondered if you were using the information the other way and using the information from the personally controlled electronic health record to help obtain the best possible medication history.
Ladies first. You're suggesting I'm a lady?
I guess, again, we were a bit lucky in that our GP local area was one of the pilot sites for the PCEHR, so we had a number of GPs on board who were desperate to, in actual fact, get their discharge summaries up to the PCEHR so they could access them. So we've been doing that ever since it was physically possible, and every single patient who signs up for a PCEHR automatically gets, assuming they've consented, of course, gets that sent up. And yes, we look at the PCHRs almost identically to the HCS system that Rory's seen. We have a little green tick on our EMR system that tells us if it's available, and if we are accredited providers using our own unique login and password, we go up to the PCHR, it records who we are and where we work for, and we can look at that. And again, exactly as Rory said, you should have gone first, Rory. If there's a little padlock on the PCHR for that particular admission, then it's not possible to go to the PCHR. So it's a nationally controlled system.
suppose all I've got to say is very similar sort of thing. The one thing I didn't mention in our talk is obviously with the software that we currently use is when we're doing an admission interview, obviously we can look at their past medicines, we can look at the formulary to see what's on, but there's now another tab there which says MPDR, which is basically the patient's e-health record. So we have the ability to go and look at the patient's e-health record, so it comes down to our software and allows us to delve deeper into it if we want to. Obviously not a lot of people seem to have personally health control records, but the option is definitely there for us. So not only are we feeding information up, they're feeding information back down to the software as well. So lovely, thank you.
Thanks for that. Helen?
Just wondering, again, Rory and Maureen, whether your systems will actually give you some of those statistics, like the high five measures. Do you look at percent of patients reconciled? Do you see any value in doing any of the sort of auditing of the quality measures?
Absolutely. Can I go? Is that all right? Sorry, thank you. We obviously, the system does have some basic statistic functions. That does need a little bit of work if you ask me, but I don't delve into that sort of thing. But we do audits separately on when people were admitted and when do they have reconciliations done and all those sorts of, and what time frame did information get sent to the GP. So every 6 months we do an audit and we obviously get information from that software. We just have to manipulate it a lot because the software doesn't have it pre-programmed in there at this stage. They're concentrating on other areas.
Okay, look, Maureen.
We're doing a tag team here. I'd just like to say that our system doesn't do it automatically either. So pretty much identical comments. It's every keystroke is recorded. Every keystroke is possible to get back out. You just would need to have people to do that.
That's good.
Do you see value in collecting some of that data?
Absolutely. Yeah.
We've been very lucky in that we've had some university researchers who've actually collected some data for us. We've been participated in quite a number of research papers. It's a very, very time-consuming thing to do. Yes, it's possible. Can you do it? And, why do you collect this data rather than that, and what are you going to use it for? So I guess that's where our IT and health managers need to focus. What data are you getting? What are you doing with it? And where are you going to present it so that you can maximise its use?
So I think Helen's point then is if you're still procuring, put some reporting functionality into the requirements before you sign a contract.
I guess, and also do you have a sense of what % of your patients will be getting reconciliation? Or, do you know, like, what your MR1 will be within 24 hours or within 48 hours?
We're currently doing an audit. I've just uploaded all the information to go through and do a random test of 120-odd patients, so we're going to be looking at that shortly. But someone else does that in safety and health, which we'd have to contact. So I don't know off the top of my head, sorry. But I do know, as a clinical pharmacist, and every single person that comes in that's under my care.
Yeah.
So,
I guess our clinical pharmacists do too, but I don't know what the figures are. I'm sorry. Yeah.
On that note, then, I guess winding to a close, I'd like to flag the Commission tries to be an evidence-based organisation. Those of you who've presented today, done work in the High Fives project, or started to look at early benefits and barriers, I would urge you to consider whether some of those things can be turned into journal articles. I think there's a paucity of journal articles about change, about implementation, about reconciliation, about harm, about adverse events. You'll probably find you've done 80% of the work, so I would urge you to think about that kind of stuff, getting your stuff up into journals. On the evidence base, the Commission always tries to see if we can do things better. Helen has included in your folder an evaluation form, so just go through and do a little bit of it. It's only one side, isn't it? One side and then another side. It's only one sheet. Could be photocopied to fit onto one A3. So I would urge you to do that. Look, I'd like to thank this afternoon's folk. I'd like to thank this morning's folk. Helen, you've done a superb job making this happen with the help of Sarah and Anna Lucia and Margaret Dogood for your leadership over the course of the project. So I wish you all a good Sydney afternoon. We've got an early mark, so feel free to mingle, and thank you once again.
I just
Wanted to thank all the High Fives hospitals for their contribution to the project over 5 years. It's a huge commitment to commit to a project for that length of time, and it's really, I think, an outstanding achievement for you guys to still be keen and motivated 5 years down the track. And I'd like to thank you all very much for that and to acknowledge that. Thanks.